Thank you, Dr. Shardaraj, for that very informative lecture. I think we were going to handle all the questions at the end. So in the interest of time, we are moving ahead, and I take great pleasure in introducing our next speaker, who's Dr. Nimantha Alvis. He's a consultant endocrinologist in Mediclinic City Hospital. So Nimantha qualified with first-class honours from the University of Sri Lanka and awarded a gold medal for his clinical medicine in Colombo. He thereafter did his PhD in UK in non-alcoholic fatty liver disease and obesity. He has many publications in obesity and diabetes. Nimantha was working as a consultant in diabetes and endocrinology and a bariatric physician at City Hospital in UK. He is also the diabetic research lead for the National Institute of Health Research, Northeast region in the UK. And he is currently based in the UAE. So over to you, Nimantha.
Thank you very much. It is indeed a pleasure as an endocrinologist to be here on World Diabetes Day. And my thanks and gratefulness to the organizing committee for giving me this opportunity to be here back in Sri Lanka. So I'm going to be talking about the tsunami of metabolic syndrome and metabolic disease and its impact on cardiovascular, coronary vascular disease. So in a general diabetes clinic, as an endocrinologist, this is a very typical patient that we would see. So someone with diabetes going on for a while that is not controlled, known to have a bit of coronary artery disease, they're obese, has uncontrolled hypertension, an LDL cholesterol that's slightly high, and possibly some raised transaminase levels. They may be on some medications such as oral hypoglycemic agents, on statins, and on antihypertensive agents when we see these patients, and sometimes we do have to take them forward in their management. So how should this patient be managed? And what I will be giving you is what the perspective of us as endocrinologists are, hopefully to support you guys in cardiology. So the metabolic syndrome as a real diagnosis, we say, is made when there are 3 or more of these conditions, and I'm sure you can identify that within this, there's definitely at least 3 of these problems in our patient, and most of our patients will have these problems. As I said, I will be touching slightly also on non-alcoholic fatty liver disease, which is not part of the metabolic syndrome currently, but there's certainly some evidence and some drive to try and include this as the liver component of the metabolic syndrome. This syndrome or metabolic syndrome is extremely prevalent. There's been quite an increase, even if you look at the US, over sort of a 30-year period. It matches obesity and type 2 diabetes, which are a massive problem worldwide, the latter being about around 7% in European populations, but driving up to about 14 to 16% if you take places like the UAE, where I am working at the moment. And about 85% of patients with type 2 diabetes also have the metabolic syndrome. So I was told to talk about a tsunami. I'm going to talk about 3 tsunamis and a mega tsunami. So my first tsunami is going to be obesity. About 68%, 2/3 of the population, can be classified as overweight based on BMI or body mass index, particularly in Western societies and even in the Middle East. And about 30 to 35% of these patients have levels of obesity, which is a BMI over 30. Worldwide, the prevalence of obesity has nearly tripled over sort of 20, 30 years. And in most countries now, overweight kills more people than being underweight. And this is not a problem only in Asia, in the world, but also in Asia. As the degree of obesity increases, and you will see on the right side of your screen that there are BMI categories, and as the categories get worse, all the features of cardiovascular and risk factors will also increase, including diabetes, sleep apnea, and fatty liver disease. So the more obese your patient is, the higher the risk that they are going to get problems with coronary artery disease and other risk factors. Obesity also reduces your lifespan. So if you are a healthy BMI, the chance of you reaching 70 years amongst the people sitting here is about 80%. But if your BMI is sort of 40 to 50, there is a 50% chance only of reaching the age of 70. And this may be due to a variety of factors, including sort of cardiovascular disease and diabetes, and even just being hit by a bus. So because of these risk factors that are there, the American Heart Association has actually put out scientific statements about obesity and the risk to cardiovascular disease, because as I said, this is the first tsunami that's going to hit the cardiologist, because we are looking at a massive increase in obesity prevalence worldwide, including in Asia. So the fat distribution is not only based, the body mass index is not the only feature that we would use to look at how obese a person is, but also where your fat is. So this article actually goes on beautifully to describe all the various places and the risks, and therefore we also know that the visceral adiposity, or the fat that's in our stomach, is the worst possible fat to have. And this is the worst sort of deposition in most Asian people. And I'm sure you notice if you look around us, we're all people who have a problem around our waist. And a high waist circumference, therefore, is the one that increases your risk of cardiovascular disease even more than what we think as body mass index. And this is also a close partner with liver fat. I don't know much about 2D echocardiograms, being an endocrinologist, but I'm sure those of you who do echoes will probably be able to identify things like pericardial fat and epicardial fat, and the relationships between these to insulin resistance and obstructive sleep apnea, etc. And we also have to identify patients, whether they're apples or pears, so wherever is their fat deposited. If the fat is around the tummy, yep, your problems of metabolic syndrome are far worse, but if your fat is lower down, you might get away with it. The impact of obesity on procedures, again, I just thought I'll put this out there because there are lots of cardiologists in the audience, and this is not for myself. So if you're doing an interventional cardiological procedure, you have a greater mortality, there's a doubling in time to reach adequate anticoagulation, and there is probably more contrast-induced nephropathy. But they didn't really show that there was much of a difference between major adverse cardiovascular sort of coronary events or GI bleeds, depending on how obese the patient was. And also there was a show of what's called the obesity paradox. This is where very low BMI patients also tend to have a higher mortality, just like people who are having a high BMI. If you look at a coronary artery bypass graft procedure and obesity, higher hospitalizations and longer hospitalization periods, and a greater frequency of atrial fibrillation for the EP people amongst you. So that's our first tsunami. And here's the second one, which is actually following on and probably very, very closely related to the first one, which is type 2 diabetes mellitus. Diabetes is a big problem, so 6 to 7% prevalence in Western countries and up to 9 to 14% in other countries, and the amount of these people with diabetes is increasing. So we're predicted by 2045 to have a doubling of the prevalence of diabetes from 390 million to 662 million people. And the problem is that the commonest cause of death in diabetes is cardiovascular disease. And a third of people with type 2 diabetes actually have this condition, some of the estimates even estimating higher. And so even otherwise, 70 to 80% of those with diabetes are at much higher risk. Previously, an endocrinologist, all we did in our diabetes clinics was look after sugar. So there was metformin, sulfonylureas, and we would keep giving patients to try and get their blood sugar as close as possible to the 7% or less mark. But this evolved. A few years later, we were told, actually, it's not only blood sugar, we've got to start looking at the weight as well. And there were great big trials, like the DIRECT trial from the UK, where they showed that actually losing a significant amount of weight can even reverse your diabetes. So we started looking at blood sugar, and we started looking at weight. And then very soon, we moved on to look at blood sugar, weight, and cardiovascular disease. And right now, we do this. We look at the cardiovascular disease, not to the extent probably that you do, but to some extent, we would look at it. But we are also now told to look at renal protection. And the main reason for the last two advances was the reason was that we've got these new SGLT2 agents and the GLP-1 agents, which are really beneficial for these conditions. Towards glycemic control, the UK PDS trial is a diabetologist's pivotal landmark trial. This was done in 1998 in the UK, and this showed that actually keeping your sugars really tightly controlled reduced microvascular diabetes complications. But a 10-year analysis showed that actually there was even macrovascular complications, and there was a 15% reduction in myocardial infarctions if you had a better, tighter glycemic control. But the latest type 2 diabetes, so this one from the American Association of Clinical Endocrinology, has given us the right not to just treat to fail, because that's what the diabetes guidelines did previously. We gave them metformin. When they failed, we added in a second agent. When they failed and everything was going off, the sugar was increasing, we added in a third agent. But that emphasis is now different, and we treat diabetes very actively. So we don't let the sugar go up. We use 2 agents at the start. We use SGLT2s at the start. We use even GLP-1s at the start. So we don't have that hierarchical system unless you're working in a health system that's like a national health economic budget-based program, probably like in the UK to some extent. Right, and the third tsunami of non-alcoholic fatty liver disease, as I said, this is considered the liver component of the metabolic syndrome, but this is extremely common as well. The problem with this is that we don't even know we have it, and 25% at least, or even I would say a higher proportion of us sitting in this hall today have probably got non-alcoholic fatty liver disease, because 80% of us have normal transaminases even if you have this. It goes up to 80% of those with type 2 diabetes. And although there is also a liver-related mortality, most patients with non-alcoholic fatty liver disease or NASH will die of cardiovascular disease. And therefore, managing this condition is also extremely important. We are fortunate that again in 2022 we have good guidelines from the American Association of Clinical Endocrinology for the management of NASH. And based on this as well, we also have scientific statements from the American Heart Association saying that actually non-alcoholic fatty liver disease is a problem for cardiovascular disease, and therefore let's start and manage this as well, because otherwise we're not going to win with trying to prevent that. So NAFLD is directly associated with cardiovascular disease because it can cause endothelial dysfunction, it can cause ectopic fat in your liver, causing problems with inflammation and also increasing fat around your heart. And it can also increase your risk factors by increasing dyslipidemia and insulin resistance as well. So a double whammy there towards cardiovascular disease. How do we manage it? Unfortunately, we do not have a medication that's specific for fatty liver disease, but it's all of the other dietetic schemes, whether it be hypocaloric or low-carb diets, restriction of sugars. Mediterranean diet actually has also helped in managing fatty liver disease, and bariatric surgery, which I will also allude to in a minute. And this time around, they've actually said pioglitazone, which I'm sure cardiologists don't really like, which is because it's a medication that we don't use in advanced heart disease, can also be used. But the GLP-1 agonists, unfortunately, which are not very widely available in Sri Lanka, can also be used. So if we are going to be managing the metabolic syndrome as a whole, the most cost-effective thing to manage would be obesity, but also watching your diabetes on the one side, keeping the sugars controlled, and also making sure that while you're doing this, you're reducing fatty liver. So 2 years down the line, this is what has happened to our patient. Hypothetically, this is a hypothetical patient which I have moved on. We find that this patient is now on an SGLT2 inhibitor like empagliflozin. He's also on a GLP-1 agonist, which is a weekly dose of semaglutide, a higher dose of statin, and so we're controlling blood pressure and we're controlling the risk factors. The patient has seen a dietitian and actually lost a lot of weight, and the HbA1c is now really well controlled. We know that we only need about 5 to 10% of weight loss to have a lot of benefits on the cardiovascular system, and the Look Ahead trial, which is a very important trial in obesity management, showed that we need 10% weight loss. But we don't just say lose it slowly, we say lose as much as you can, as soon as you can. Because the more weight you lose, you can actually change the course of disease. You can change the course of diabetes by losing significant amounts of weight, but we just definitely know that the benefit starts quite early. So there are all these non-pharmacological measures, such as dietetic changes, and we want to say there that interventions that are medical related really haven't shown a huge difference in coronary artery disease, but it does reduce some of the risk factors. The Look Ahead in 9.5 to 10 years didn't again show a reduction in coronary artery disease. But intermittent fasting and Mediterranean diets, these are getting more popular and showing more and more benefit on coronary artery disease as well as aerobic exercise schemes. I want to spend a little time on the pharmacological treatments, although I appreciate some of these are not available here. Metformin is great. This is our bread and butter. We always start patients on metformin, and certainly this is something to carry on with, not purely for weight loss. I'm talking about patients who also have perhaps insulin resistance and prediabetes, or definitely for type 2 diabetes. The group of SGLT2 inhibitors, I'm sure we are familiar with. I understand some of these are available here. These will reduce blood sugar, also cause a bit of weight loss because you will lose about 400 calories in urine, and significant benefit in heart failure and coronary outcomes. And there's also a renal benefit, and recent research showing that even if you're not diabetic, there is benefit on heart failure and benefit on renal protection. So certainly a medication that should be widely used as much as possible if finances do allow that to be used. The mechanisms of benefit of SGLT2s are growing every day. It's not only related to fluid depletion, and there are a lot of benefits even on, they say, on the cardiac muscle, and the generation of ketones is also helping muscle function in the heart. And so many mechanisms coming out saying that actually these are very beneficial for renal and cardiac protection, particularly for heart failure management. So the studies are out there, the cardiovascular trials have been done, and if you do have the time, read the EMPA-REG, CANVAS, and DECLARE programs for the three main agents, and they will give you a lot of evidence. But I would suggest we don't split hairs on these, because the starting population for each of these cardiovascular trials was different, with high-risk populations in EMPA-REG, very low-risk populations in DECLARE, but a mild, like a mid-range population in the CANVAS program. Heart failure benefit across the board was excellent, and this is real-world evidence showing that all of these hazard ratios were on the left side of the line. We come on to GLP-1s. So these are mainly injections. We have daily injections such as liraglutide for weight loss, comes as a form called Saxenda. It's licensed for weight loss without diabetes, and also Victoza form that is evident for diabetes. But we have also moved on from here in most Western countries, and particularly in the Middle East. We use the weekly preparations, so semaglutide, the 1 milligram, 2 milligram, and there is also a preparation for purely for weight loss called Wegovy, going up to 2.4 milligrams, and there's dulaglutide. They have also come up with an oral semaglutide tablet now, which can be taken on a daily basis, and again showing excellent benefit for diabetes and weight loss, and perhaps this might be one of the things that might come in the future if injections cannot be used. But the new kid on the block actually for us, this has stopped moving. Sorry, the slides have stopped moving. Oops. Sorry. So these are the GLP-1 receptor agonist trials across cardiovascular disease, and it's going off by itself. And this is the new kid on the block, as I said. This is a Mounjaro, or this is a GLP-GIP agonist. It's called tirzepatide. And we are very fortunate in the UAE that just we are the second country after the United States to receive this product, and we have managed to use it. I think in my clinic I have about 200 patients now, and excellent benefit for weight loss, excellent benefit for diabetes. Again, it's a weekly injection, and it has also shown a lot of benefit in blood pressure reduction, triglyceride reduction, and also in fatty liver disease. And up to 40% of patients will lose more than 15% of their body weight. So excellent weight loss to even affect the course of diabetes, the course of obesity. We know that there are over 280 conditions that are improved by weight loss, and this is certainly going to be a game changer, if not replace bariatric surgery and make the surgeons very nervous. So here are the slides showing you the weight loss and the sugar control with tirzepatide. This was compared to semaglutide, which was thought to be the best treatment, and actually the lowest dose of tirzepatide had even a better benefit than the highest dose of semaglutide. Blood pressure and triglyceride levels, again showing similar excellent reductions. So these are all cardiovascular risk factors, and also in fatty liver disease, showing that there was a clearance of liver fat to quite a large extent. So a couple of slides on the place of bariatric surgery, because again, I'm sure a lot of bariatric surgery is also happening in this part of the world. And the conclusions that we have are this is really good, sustained weight loss in large magnitude, which can change the course of disease. So it's good for prevention of diabetes, good for remission. It reduces micro and macrovascular disease and maintains it, and also improves other cardiovascular risk factors. We have very new guidelines from the ASMBS and IFSO. This has now brought the actual the BMI criteria much lower. We used to say a BMI over 40, but now they said actually BMI over 35 with no risk factors, you can also be eligible for bariatric surgery and metabolic surgery. And in Asian populations, a BMI of over 27, and you would be eligible to have bariatric surgery. So these are very new guidelines, 2022, I would say even August, September. And this will now start making bariatric surgery more accessible if cost is not an issue. But here's our mega tsunami. We have to think about the kids, because this is where our future generation is coming up from. And the problem is not only in the Western world, but in Africa, for example, the overweight population in under 5s increased by 24% over a 20-year period. And about half the under 5s overweight or obese live in Asia. And this is going to be an obesity problem also in the adolescents. So these are children who started 10 years ago. We've not done enough about it. So they've now gone into the adolescent groups and they are still obese. And these are our future adults in the next 5 to 10 years. And there's more to come behind that in the under 5s. So it's certainly a time that we should be responding to it. And our response to metabolic syndrome should be a population-based prevention program. While we manage our own patients in the diabetes clinics, in the cardiovascular clinics, we should also be managing and doing preventive work in the population, because that's the most cost-effective way of doing things. Children need to be educated, and legislation to reduce sugar and calorie labels must be taken up, and therefore manage the patients at risk. So, ladies and gentlemen, the mega tsunami is coming. Are we ready? This is not a work for endocrinologists or bariatric physicians like myself, but a job for all of us out there in this audience and for the general population, teachers and parents. And I've summarized there saying that these cardiovascular problems are issues, and we do, as endocrinologists, as internal medicine doctors, also start treating them and managing these complications and risk factors before they can even reach yourselves as cardiologists. But prevention and early childhood intervention is absolutely key. Many thanks for your attention, and again for this invitation.